I'm board-certified emergency physician Dr. Ryan Stanton. I'm also the medical director for Lexington Fire and EMS. Today, we want to talk about the worst drug abuse crisis and epidemic in U.S. history, the opioid abuse crisis, starting with prescription pills and now moving on to heroin and other substances that are killing Americans by the thousands. Today, we want to talk about how we got here, how opioids act on the body and cause addiction, where we go from here, and more importantly, how do we recover those that are addicted and prevent further addictions down the road. The idea of addiction is one where the body no longer has a choice. You no longer have the power to decide whether I want to use or not. It's basically your brain telling you that you have to have it, as much as you would food, water, hygiene, or breathing on a daily basis. There's actually a really good study that was performed on mice to see how addiction worked. And they found that the mice, when it comes to getting addicted to these substances, would constantly hit the button to get more of that substance to the point that they would eventually starve to death because they wouldn't actually even seek the food and water that was in the cage. And it's very similar with humans. It's very similar with us. People that are in the grips of addiction will actually give up everything in their life because their body is telling them when they are coming off these medications and these drugs that that's the only thing they need right now. The only thing they need to survive are these drugs, and they will give up everything to do that. Opioids act on the reward center of the brain, the part of the brain that releases dopamine that allows us to feel a sense of accomplishment, of euphoria, like when you win a large race or have a huge accomplishment at work. Unfortunately, what they do, like any form of addiction, is basically rewire the brain. Think of the brain as almost a circuit board. And what these substances do, whether it's alcohol, tobacco, opioids, or other substances, it rewires that brain to where it thinks it has to have those substances in order to survive. And that rewiring of the brain actually has more of an effect when it comes to young people. A study came out that demonstrated that anybody under age 15 that drinks alcohol basically has a 50% lifetime risk of addiction, where if they wait until age 21, that risk is only about 10%. The reason being the development of the brain. During the development of brain, and especially the frontal lobe of the brain, it's very easy for substances to rewire the brain, to put in that pathway for addiction. Once we get older, it's much more difficult to put that pathway into place. And so the earlier we're seeing people use substances, whether it's tobacco, alcohol, marijuana, or opioid-based medications, we're establishing that pathway that increases their risk of addiction through life. This started back in 1980 with a very simple 5-sentence report in the New England Journal of Medicine called Porter and Jick. Basically, they reported that thousands of patients that were closely monitored, reviewed after postoperative stays in hospital had a very low risk of opioid addiction. Then in 1986, another story based on 37 patients actually came out and said there was a very low risk, less than 1%, of the use of opioids in secondary addiction. These two articles were used in 1995 as the basis for the fifth vital sign. The American Pain Society developed the fifth vital sign as pain, a way to measure people's suffering. And it became the law of the land, basically something that we evaluated across the country as the vital signs when we evaluate patients and monitor them in the hospital. In 2001, JCAHO released their report, making pain a significant source for evaluation and a goal in hospital and pain management. Unfortunately, over time, opioids basically reset our sense of pain. Though 20 years ago we didn't have an opioid abuse crisis and now we have 2 million people addicted, the actual complaints and reports of pain in the United States have changed not at all. We are the exact same painful culture that we were 20 years ago. The numbers are staggering. The United States consumes over 99% of the world's supply of hydrocodone, over 90% of the world's supply of opioids altogether. It's an issue that has exploded across the United States and now beyond. The challenge is that when we reset our pain threshold, or what we feel in terms of pain, we actually need more of those opioid-based medications just to get where we were before we had them to begin with. So if you think of it as a bar graph, starting at the very bottom with where you are when you have no medications, and the top of the graph, which is pain-free, opioids actually shift that graph up as you go. The more you take, the more sensitive you are to pain, meaning that when you come off those medications, the more sensitive you are to those pain and the more medications you need just to get back to ground zero when it comes to your sense of pain. So as time has gone on, people needed more and more opioids. The pharmaceutical industry was happy to oblige, increasing the dosages and strengths that were available on the market through prescriptions and patches and everything else that we could provide in the emergency room, hospitals, and beyond. Arthur Sackler bought Purdue Pharmaceuticals, and he was actually a man that revolutionized the marketing of medications and pharmaceuticals in the United States. He was the first to produce a billion-dollar drug, that being Valium, another potentially addictive and controlled substance. But in 1996, they developed a drug that I think everybody knows the name, and that's OxyContin. It was basically marketed as addiction-free, using that Porter and Jick article from the New England Journal of Medicine for the basis of reporting that there was no way people are going to get addicted to this medication. Over time, the use of OxyContin exploded. 32,000 coupons for free prescriptions, more than 20,000 educational programs. Eventually, more than 50% of the prescriptions were being written by primary care physicians with no formal training in pain management and addiction evaluation and treatment. The profits from OxyContin went from $45 million to $3.1 billion. An explosion in prescriptions, easily becoming one of the most prescribed and profitable drugs in the history of the United States. As that need for stronger and stronger doses increased, so did the need for drugs like heroin. The heroin that would keep them to that baseline that they needed to function on a daily basis. What dealers would do would be to find middle America, smaller places where they'd never been before, places where critical mass had never been reached, to bring the demand into these areas. So they'd camp out outside of pain clinics and other places where they knew high concentration of opioid addicts would hang out. And they would offer these products, heroin that was stronger and cheaper than what they were getting inside the pain clinics. Unfortunately, with that came the deaths. The overdose deaths that started hitting all over the country. Batches, dozens in small towns that had never had overdoses in the past. Places in southeastern Kentucky that were now seeing an entire generation being lost to addiction and overdoses. Drugs, whether it's a prescription medication or one bought off the street, typically come as a solid or powdered format. And then it comes into how do we get it into the form that's going to be injected, whether it's dissolved in a liquid, whether it's water, saliva, or whatever the source may be, whether it's cooked down to make it into a format that's easier to inject. All of these not only are to make it to where it can fit through these needles and be injected, but also increases the risks associated with those drugs. The risks associated with contamination, overdose, and the potential of significant infections. Actually, recently, just a few weeks ago, I had a patient come in. He was going to be admitted secondary to sepsis and endocarditis, very significant, potentially deadly infections. And that's when he informed me that he still had a needle in his arm. And we actually got x-rays and demonstrated this small, about half-inch needle stuck in his arm that will have to be surgically removed. And the bigger challenge is, a lot of times, these are in the soft tissues, pretty easy to access. But if you think about drug abuse, they're trying to hit the vessels. So these needles can be very close to vessels, and worst case scenario is they break off in the vessel and can actually then be transported through the vessels into other parts of the body, including the heart and the lungs, where they become very difficult to retrieve, requiring surgery and potentially causing life-threatening complications. The primary weapon in our fight against overdoses is right here. It's Narcan, or naloxone. These are the two most common formulations carried by our paramedics and police services, whether it's the intravenous or intramuscular version, or a version that goes up the nose. All of these are used to help fight off the opioid. It prevents them from being able to bind to the places in the body where the opioids bind up to cause their effects. Basically, being a goalkeeper for the body, keeping them from scoring when it comes to getting the ball into the goal. The problem in Narcan is it doesn't have a lot of endurance. It doesn't last very long, usually about 45 minutes before its effects wear off. And that's okay when it comes to heroin. Heroin's a very fast-acting drug. It's fast on and fast off when we intervene. Now we're seeing other substances in the heroin, whether it's fentanyl, methadone, carfentanil, sufentanil, combinations of medications that take heroin and amp up the risk of death exponentially. In the EMS and emergency services, we're seeing patients that are requiring multiple doses of naloxone to help get them breathing again. I actually talked to a DEA agent and asked him if we were seeing the elephant tranquilizer version of the fentanyl. He said, no, you're not going to see that in the emergency room because they're not going to make it to the emergency room. They're going to be found dead. With the Lexington Fire Department, I've responded to a number of overdoses, and we'll enter these homes and the people will be found on the floor, breathing 2, 3, 4 times per minute, blue, looking like, well, as close as you can to death without being dead. We give them Narcan, they start to wake up, and when they wake up, they have no idea what's happened. And it's a terribly sad situation when you have to tell somebody when they wake up that they almost died today. That if it wouldn't have been for somebody intervening, whether that's a bystander that had a Narcan kit, whether it's the police or EMS that were there to help provide first aid, or arriving here in the emergency department where we can give medications and protect the airway. People don't realize on these overdoses how close they come to dying on a daily basis. This area has been hit especially hard with the opioid abuse epidemic, and that's for several reasons. One is during this time that we're seeing this growth in the medications, we're also seeing the pain associated with manual labor in these areas. They were able to get these medications to treat their chronic pain, but also sell them. A prescription could be given to a person. They could take the ones they needed for their chronic pain, but then they would sell what was left over to help make money to pay their bills. At $1 a milligram, it became very easy for these prescriptions to make ends meet. I actually talked to a patient one time in the emergency room. He was going down to Florida, and he said he would go into this clinic, and it was almost like a menu at a fast food restaurant. And he would say, I want one of this, one of this, one of this. He would leave with hundreds of pills in his pockets. Basically, a small market developed, sending folks down to these clinics and saying, we'll support you, we'll bankroll you to go down there, and in payment you give us 100 or 200 of your pills. They would return back here to the bluegrass to sell those medications to people around their community, actually just producing an explosion in addiction and abuse throughout the region. And how bad has it gotten? The CDC reported that in 2015, 1,273 Kentuckians lost their lives to opioid overdoses. And in 2010, opioid overdoses passed MVCs, or motor vehicle collisions, as the #1 accidental cause of death in the United States. Every day, about 1,000 visits to United States emergency departments are associated with the misuse of opioid medications and substances. I think it's very clear that we have a problem, and a problem that almost seems insurmountable when you look at it. But there's things we can do. What can we do to help dig out of this issue? We have to figure out ways to get you out of that addiction, that rescue, those interventions. And I think that's where we get when it comes to the Narcan programs that bring people to the ER, the ability to intervene, to have a sit down with them, to help get them into programs, whether it's inpatient program, outpatient program, or the resources they need for recovery. Because if we don't have recovery, all we're going to do is change the substance. As these people advance in their addiction, they're either going to change the substance or they're going to die. And it's as simple as that. And without us intervening as a culture, society, healthcare, and public alike, we're going to lose thousands. We as healthcare need to grasp this, understand that we had been led astray and that we've been practicing what was basically misguided medicine for the last 15 to 20 years. We need to do what it takes to treat people based on their need and what works, and help prevent addiction and the abuse of these medications. As for the public, don't go to the hospital demanding opioids. Go into the hospital with an open mind. Just as I say, don't go in demanding antibiotics for your upper respiratory infection. We want you to come in and ask, what's the best thing for this treatment? What can we do to get better and to help prevent pain in the future? And what you'll find out, there are a lot of things that are more beneficial, helpful, and have a lot less risks to them. The key in healthcare is it's our opportunity to make the first step to help prevent future addicts and future abuse epidemics.